and you're live.
Good evening, everyone. I'm Councillor Stephen Allen Breetis, leader of the council and responsible for adult social care and health and wellbeing board here in the London Borough of Merton. We have our meeting of our health and wellbeing board community subgroup, and you're all very, very welcome. I'll just seek apologies from Clarissa Larson, who's been very helpful to me in setting up this meeting. Clarissa, over to you.
So we've received apologies from Dr. Mohan Sekaran and also from James Blythe for today.
Thank you, Clarissa. This is a very important subgroup. As you all know, the government has asked every local authority to produce an outbreak control plan, setting out proposals for test, track and trace. And this subgroup will support the implementation of Merton's COVID outbreak control plan, which will deliver a member-led local guidance through a member-led local guidance board. We'll have oversight of communication with the general public on test, track and trace, and we'll be focusing on protecting vulnerable communities in particular. The subgroup will also have oversight on the work of the impact of COVID on vulnerable communities, involving a real lived experience and ongoing community dialogue. So a very, very crucial and important subgroup. There was some thought that the major health and wellbeing board should undertake this work, but obviously, as we all know, health and wellbeing boards meetings, very important meetings, but this meeting, this subgroup is best placed to deal with the issues to hand, as it will be meeting monthly right up to April of next year. So you're all very, very welcome. I would like now to ask all of us here to introduce ourselves, and I hope I get this right. So I'm Stephen Allen Breetis, leader of the council. Kaz, do you want to introduce yourself?
Hi, good evening, everybody. My name is Kaz Obuka. I am Head of Patient and Public Involvement and Equalities for Merton and Wandsworth.
Thank you. Abby, do you want to introduce yourself?
Thank you, Stephen. Evening, everyone. I'm Abby Safalu. I'm a trustee at MBSC, the Merton Voluntary Services Council. In my day job, I'm a strategy lead at HMRC.
Thank you, Abby. Councillor Stringer, do you want to introduce yourself?
Hello, good evening. I'm Councillor Eleanor Stringer. I am the Cabinet Member for Children's Services and Education.
Thank you, Ellie. And over to Councillor Una Moulton. Una, do you want to introduce yourself?
Yeah. Good evening, everyone. I'm Councillor Una Moulton. I'm one of the councillors. I think I'm the representative for the opposition on this particular panel, and I'm also the spokesman, Conservative spokesman on health and wellbeing.
Thank you, Una. Rob Clark, over to you.
Good evening, everyone. My name's Rob Clark, and I'm Chief Executive of Age UK Merton.
Thank you, a lovely organisation. And over to Dagmar.
Hi everybody, I'm Dagmar Zoyner. I'm the Director of Public Health in the London Borough of Merton.
And thank you, Dagmar, and thank you for all your work on protecting the residents here, well, everyone, for all their hard work. And over to Councillor Rebecca Lanning.
Hi, good evening everyone. I'm Councillor Rebecca Lanning, and I'm a councillor for Cricket Green Ward.
Thank you. Martin, do you want to introduce yourself?
Hi there, my name is Martin and I work as a young inspector. I tend to work with projects in youth work and public health.
Thank you, Martin, and thank you for joining us. We do love our young inspectors. Thank you. Vasa, over to you.
Hello, I'm a GP and I look after the people who live in Lower Morden, end of Merton.
Thank you very much. And I just wanted to thank Clarissa, Rosie, Ola and Stella for all their work in getting this meeting together. Have I missed anyone out? I don't think so. Thank you. Now we go on to the major substance of our meeting tonight. That's the local outbreak control plan, and over to Dagmar.
Yeah, so we, as Councillor Stephen Alambritis already alluded to, so the purpose of us coming together, working under the Health and Wellbeing Board, is twofold, and both in our reasons of being have links to COVID. One is in that this group has oversight of the duty of Merton Council in outbreak control, and I will tell you a little bit with the slides. And the other one is that we all know now that COVID has disproportionately impacted on different groups in our community, and we want to give voice to our community because we are now gathering quite a lot of data that tells one bit of a story, but we're very keen that we don't really understand it unless we give voice to our local people. And so that is the project that we call Lived Experience, and I'll tell you a little bit more about that in a minute, so that we as a group have oversight of outbreak control and over the lived experience bit. So that's what the slides try to give you a bit of background information. So Clarissa, are you going to help me? We start with the outbreak control. So yeah, if you can move on, that was just the sort of the pretty first start. So hopefully you might have had a little bit of spare time, wishful thinking, to have a look at our outbreak control document. We all had to publish one, so it is a duty that local authorities got from the Department of Health and Social Care. So it wasn't discretionary, we have to do it. And we had to publish it by the end of June. So the link is the Merton document. We try to make it accessible and brief. So I, in a way, urge you as the group that you do have a look. Now, in brief, what it does, it describes who has to do what when we have a local outbreak of COVID. And our really important partner in all of this is Public Health England. Logically, they are the agency for infection control and outbreak control. And the name you will hear a lot is LCRC. I've translated this jargon for you here. So it's the London Coronavirus Resilience Cell. I'm labouring on this because they are such an important partner. And then obviously we work with all the organisations that you and the Health and Wellbeing Board represent. So the voluntary sector, absolutely crucial, our NHS, MVSC, and so on. And what is also important is that local authority can't do it on their own. So outbreak control works by working together, and in particular, we need to work together with the NHS Test and Trace Service. So as you probably will have all heard in the press, we've all managed to get through the acute response of COVID, and now there are outbreaks. Yeah, so that is one of the characteristics of the virus. It tends to create outbreaks. And in order to control them, what needs to happen is that people, the moment they have even the mildest symptoms, test. Really, really important. Even if they're not that ill, they need to test. This is a national service. It's run through the NHS and some commercial laboratories. You can either ring 119 or you can go on the internet. You can order it through the post. You can drive through. So there are all sorts of ways how you can get the test. And then the other really important bit is that if people get a positive result, they need to engage with contact tracing. Again, the contact tracing is run by the NHS. So every positive result is transferred to NHS contact tracers and they will call. And again, you can imagine people think, oh God, that's a hassle. But it is absolutely important because this is our main tool to prevent outbreaks from spreading. So really important that we are not replacing NHS test and trace, we support it and complement it. And as I said in the next paragraph, it's a really important part of the overall policy to protect us all. And you will have heard people are now worried that there might be a second wave coming, particularly in the autumn when everybody moves from outside to inside. So our work locally is meant to prevent or at least flatten if a second wave should come, and really allows us to go back to in some type of normality so that businesses can open up again. We can come fully out of lockdown and people really can go about their livelihoods. If you want to read a little bit more about how it all works and hangs together, I would recommend the CONTAIN framework. So that's the jargon the government now uses, that we want to contain the virus and in how we try to manage it. Important for us to understand, and Stephen already mentioned that a little bit, so our group as well. The initial timeline for this enhanced, what I call response readiness, is from now, where we're in it, to at least the end of March. So we think we must cover the autumn and winter. That's all when we all get a bit jittery. And then there's really big wishful thinking that maybe by spring next year, we might have left the sort of COVID behind. But it gives you at least an initial time frame, and then obviously as data become available, we amend as we go along. So that just is a very potted version. If you give me the next slide, I will tell you a little bit what we actually do. So the key steps and control measures. And the first thing what we do is that we actually need to identify what we call high-risk settings and communities, because we want to be on the forefoot. We don't want to be found in the middle of an outbreak. We want to ideally prevent it. And when we talk about high-risk settings or communities, that's where you all come in. So don't snooze and don't do your emails. This is where we need you. One characteristic in terms of settings is lots of people in one place, crowded places. You will have all be aware of care homes have been a very high risk setting, very unfortunate high risk setting, because lots of people and potential infections all in one place. But in where we want your intelligence and information as well is other settings that we might have overlooked. And then, and that's why it's in red, we want to proactively communicate and engage. And we proactively have to somehow convince people that testing and contact tracing is the right thing. And the important bit is we can't take it for granted, because inside work in London has clearly shown that loads of communities are not particularly convinced that testing is the right thing. They have either don't know how to go about it, or they're suspicious, they're scared, they haven't got the trust. And then you put on top of that the idea of contact tracing. People need to trust that this is for the good of the whole community. And we need you and your connections into the community to help us. Because the learning is that just having on the whatever daily news all the information doesn't mean that people, when they start to have symptoms, rush and comply. We do surveillance, and I will show you a slide how we do it. So we pore over daily cases and contacts. So I can tell you how many new cases there have been in Merton. And then very, very important point is the notification. So if I feel or see that with the data I receive every day, that there might be an outbreak. An outbreak means that cases are linked. I will speak to my colleagues in Public Health England, and equally Public Health England across the whole of London looks at the data, studies the data, and will get in contact with me if they find any connections and any risk of an outbreak. What we then do is a risk assessment, and then we call others. We might call you, we might call the police, we might call the NHS, often around the table, depending on what it is. And we do an action plan. And just as a reminder, we haven't got that many control measures. That's why it's so important that the testing and contact tracing works. The generic ones you should by now really, really know. Social distancing, hand washing, and the facial coverings. Now, saying is one thing, doing is another. So how can we really promote? And then really important is the self-isolation. So if you are a contact or if you have tested positive, you need to self-isolate. Now, again, that's easier said than done. Furlough is coming to an end. If your livelihood depends on you going to work and you're not particularly sick, it is tricky. We can't just say, oh, you self-isolate, the end. So we've got some support up our sleeve. So if people have difficulty in self-isolating, they need to let us know rather than not doing it. And again, the voluntary sector has played a super role. In the community hub that we had when we were in the response phase has really helped, helped people who had to self-isolate for long times, the shielders, with food parcels, with shopping, with medicines. So really brilliant community solidarity. And we still have this to be stood up any moment. Sometimes we have to ask staff to self-isolate. It was a big issue in care homes. Again, you can say, please all self-isolate. And then what about service continuity? Again, if there's a problem, come back and we can help. That is the big message. Infection protection and control advice. Really, really important. People often ask, how am I going to clean? What does it mean? And very, very important around PPE, so protective, personal protective equipment. For example, in our outbreak control, we've got 3 days emergency supply. If it is necessary in an outbreak, it's there available. We can do enhanced testing. You might have heard about mobile testing units. They come regularly to Merton. We can also, if we should have an outbreak, ask for one specifically to come to a certain place. Then we can test lots of people in one go. And sometimes we do enhanced tracing and case finding. That's a sort of detective work, and we work very closely with our environmental health officers. They can go to premises. They can actually look and check out where an infection could have originated from. So it is a bit like a detective's work. And then finally, and they come at the bottom, we have powers, and we have got new legal powers, and they are about closures, lockdowns, and they are the thing that people don't like and we don't like. And they are sometimes quite difficult to enforce. So we would always try to find consensus. And when, to be honest, in care homes, for example, we had to close care homes to admissions, we had to do that. We have managed to do that consensually. But you will have seen up and down the country, lockdowns have been imposed. And it's tough on people, it's tough on businesses that just start to come round. So all in all, we have to do everything very proportionate and with people and with the community. Everything is underpinned by communication, so you all play a really important role. And I'm very happy to see Kaz here from the CCG being really closely linked with comms. That hopefully gives you a bit about the tools that we have. If you give me the next slide, Clarissa. Won't take long to go through a rather sort of tedious looking diagram. Just want to point out where we sit. So the Health and Wellbeing Community Subgroup is actually a really important part in the governance of outbreak control. So I think this group needs to understand its significance, because the understanding up and down the country now is that clearly outbreak control, there is some technical stuff involved and the health protection experts all pore over data, etc. But ultimately, I've listed you the control measures. They only work if we have community solidarity, and that's where you come in. Yeah. So that's it gives you a little overview. And then Clarissa, if you give me the last slide. So that just shows you a little bit what we're actually doing, and I'm absolutely not expecting you to study the slide in detail, but what you will see is these are our daily cases in Merton, yeah, day by day. So or me and my teams, we have a handle on what are the cases, where are the cases, and then we look about the contacts, and we have some really important markers. So for example, test positivity, you can just about imagine if only 0.3% of the people who get a test come back with a positive test, then I can relax. What happened when you remember in Leicester or now in Oldham, Greater Manchester, all of a sudden the test positivity shot up. It's 5, 6, 7%. You know, it's a marker, because you can imagine if all of a sudden those who test all come back positive, there's more around in the community. So that is the type of surveillance that we are doing day in, day out. And we, as that community-facing group, we have to have a bit of a handle of where we are, and most importantly, let the community also know where we are, so that they are not in a way all of a sudden have surprises put upon them. I stop here. Hopefully it wasn't too boring or technical for you, but these are the sort of the tools of the trade, and I wanted you to be aware of the basics. So I'm just opening up for some more sort of understanding questions. We have a longer discussion after I finish with the second part.
Okay.
So any questions that you have in terms of understanding about our tools for the trade?
Okay, well, thank you. Any questions to Dagmar? Can I ask one? When do the police, can you just clarify the role of the police?
Yeah. So police is a really important partner, because as you can understand, in any enforcement we work with the police, and opening up again, coming out of lockdown, we work very, very closely with the police. So in the diagram with the green bits in the governance diagram, I don't know whether Clarissa can fish it out again, but you will find it. We've got the Borough Resilience Forum. This is our partnership board. So if you go one back, that's it. You see in the light green in the middle, the Borough Resilience Forum. So that is our partnership group, where we work with the police. We work with the police, the NHS, the college, our providers, our healthcare providers. So we meet on a monthly basis, and we did scenario planning. So what if and who plays what role? And if we in Merton would get into a pickle, because obviously outbreaks don't really respect any borders, so it might spill over. It might be a bit of Wandsworth or, you know, Lambeth. We've also got a direct line to the sub-regional transition coordination group. It's a bit of a mouthful, but it's our sub-regional chief executives of the local authorities sitting together with police and NHS at a sub-regional level. And there's also another link. If it gets really bad, like we've seen in Greater Manchester, then we would go also up to London level. So we've got a sort of escalation built in because the speed sometimes with which the situation can change, it can be quite alarming. So we need to be ready to ask for help if necessary.
And just me again before I ask others.
Yeah.
And is the police presence based on the Borough Command Unit formation?
Yes, yeah, on the BCUs.
Thank you. Any other questions for Dagmar? Councillor Stringer and then Abby.
Thank you very much, Dagmar. That was very clear. I've got a question specifically related to schools, but I imagine it applies to all other institutions, which is to check my understanding of Merton's role in advising any institution to close. Mm-hmm. My understanding it will be similar to before lockdown, when we would provide advice on what you should do from public health, but not on whether you should close or not. Is that right?
Yes. So again, I think it's a really good question. So that's absolutely how it worked. Where there are some discussions, and in a way how powers are playing out is evolving and we are learning. I'm not sure whether I could envisage a situation where central government is so convinced that schools play a really important part in fueling a resurgence that they might step in and create new powers that go above in the autonomy of the school. But for the time being, within the existing powers, you're absolutely right. So we advise, and we have had really good preparation with the schools. I mean, it is only a month or a bit more than a month, so really important. But ultimately, at the moment, you're absolutely right. It's the school that makes the decision.
Abby.
Thanks, Stephen. Thanks, Dagmar. I think that background was really helpful to see. The question I had was really just about the timeline of Outbreak. So you talked about kind of March 2021 as a kind of optimistic point where we might hope to kind of see the other side of this. I'm assuming that's kind of the view broadly across England and kind of PHE's view as well. But I just wondered if we were doing a bit of kind of insight gathering about how cases are faring in Merton, maybe what our timeline looks like. I asked because I saw a map recently of London, and looking at the kind of different rates of cases across London even is so diverse. So just wondered if that's something we're going to think about in terms of stats.
I'm not 100% sure whether I completely got the question. So if I'm talking, stuff that doesn't answer it, just stop me. The timeline is a best guess, yeah, and it's a bit of wishful thinking, and it's also, it has some pragmatism involved, because some of the preparation and funding that we got is all based on a rough idea that at the moment, although infection rates are still relatively low, we need to be fully prepared for a potential second wave, get us through the winter and spring. And during that time, we will reassess, because who knows, some infections do third waves, yeah, or we might live with them. But it's the best guess at the moment, and that is the usual estimation that is used across the whole of London. But I might have missed some bits, Abby. If I'm not answered it properly, do help me.
Abby, no, did you want to come back?
Thank you. The point you've just made about, that's it's tied to kind of funding and future decisions, more centrally, that makes sense to me. I guess it was just thinking, this is a local group, and just thinking, how are we watching or kind of monitoring how those cases are faring for Merton? In terms of the map I saw, I mean, it was just a piece of news, but it's showing that we're kind of faring a lot better than some of the other regions. So really just thinking about how we continue to monitor our progress and see whether, things are working kind of just as business as usual interventions, or whether there are kind of more serious or bigger interventions we might need to make.
Thank you. I think Abby was referring to, probably the Evening Standard had a diagram, I think, of the whole of London, and Havering and Merton were the lowest in terms of infection rates, around up to the week beginning the 30th of July. 2.4 per 100,000 of population. And we are London, we are one place, so we don't need to kind of say, oh, we're okay, as it were. To what extent do we say that, Dagmar?
Okay, yeah, got it. So if you give me that slide again, that colourful slide about the surveillance, Clarissa. One thing that you will see is that it fluctuates a lot. And, I get that data every morning around sort of mid-morning. And, with some trepidation, I open that file going, where's Merton, where's Merton? Oh, 0. Whew, I think home and dry for the day. And you saw on the 25th of June, we had 6. Yeah. And we hadn't 6 before ever. So I started to really jitter. I said, oh my God, is this it? Yeah. So what it shows you is it fluctuates a lot. So I don't think we are home and dry at all. And it can change very quickly. So at the moment, in Merton actually looks quite good, but we had 4 on Sunday. That will kick us again into slightly less helpful territory. And if you, for example, look at Hackney, which was fine until it had an outbreak in the Jewish community, that really escalated quite a bit. I think they've got it a bit more under control. We always compare, and I am linked up with not only the sub-regional groups, we contrast and compare all the time, but with London on a weekly basis. And we are just looking how we can share some weekly oversight slides with you lot as well. Yeah, so Abby, that you get a little bit of an understanding, not all the technical stuff, but that you can see how our position actually changes all the time. Yeah, and we really have to be very vigilant. And what the London folks also do, because you need bigger numbers, is that they start to put trend lines under the wiggles to see, are we actually creeping up? And there has been some suggestion now that there is not only the outbreaks that then go away again, that there is a bit of creep, yeah, and that's what people get very jittery about. But what I also always need to urge us is that we need to be proportionate. Yeah. So at the moment, I also monitor 1-1 calls. I monitor the hospital admissions, and Vasa will do the same, and the CCG is fully aware that at the moment the people who are symptomatic aren't all ending up in hospital. In fact, very few do. So hospital admissions are still going down, deaths are going down, which is all very good. So we need to be proportionate in our response to what we are seeing. Why we are reacting so quickly is because we have got the anxiety that it will spread from the people who have a light problem or no problem to those who get it very seriously. And we don't know enough yet whether the second wave will behave like the first wave. And you might have seen in the media as well, there is loads of stuff in the media And some of the modelers say, oh my God, the potential winter curve might be even worse. Some say it might be milder. We simply do not know. So it is the preparedness, but it needs to be proportionate, because we mustn't underestimate what I call the collateral damage. So closing down, locking down, in sending the businesses being ready to open, then no, you can't open. These are livelihoods of people, and they cause a lot of collateral damage that we don't count in lives at the moment, but we might have to count in lives later. So it is for us to get that balance.
Thank you. Councillor Una Moulton.
Thank you. Dagmar, I think that's very succinct, and I praise you for being able to do that, because it's a hugely complex scene, really. I wanted to really follow on from what Eleanor was talking about with the schools, because also in the national press, as we know, there's been talk about from scientists that there should be a choice between schools and pubs. I mean, that puts it very crudely, but I mean, obviously, if you're saying that, I mean, I'm not sure quite exactly where our responsibility sits in terms of that sort of choice. You know, are we as members and this committee going to be responsible for that sort of choice where we you know, and I think you've touched on it, because obviously we want to keep businesses open. We don't want too much uncertainty. It goes the same for schools. You know, I mean, people want to feel that their child's going to go back, that they're going to, you know, you don't want a whole load of stop-start, but equally, as you were very well saying, this, you know, this really nasty virus is clearly, you know, out, and it's very malicious, and it spreads very fast, and da-da-da-da. So it's these sort of things of exactly where we sit in that sort of structure of at what point, you know, are we making these pretty huge choices? I mean, I guess, you know, that the leader has a huge part in that too, but it's quite a massive point of, and it's so important. So I just wanted to get a little bit of clarification, I suppose.
Yeah, and I think it's really fair. And for me, the slightly reassuring bit in a way is that we're not on our own. Yeah, so we would never just say, oh, it's just in us that have to make all these decisions. Of course, we contribute, and we want to contribute, and that's why we are all together, because we can bring perspectives and aspects and understanding and granularity that others can't, and that is important. But we are never completely on our own. So in a little bit in how we actually responded when we were in the big wave. Initially it was Merton, but when the outbreak became like a civil emergency, we had to relinquish some of our local decision making in favor of saying a London coordination of this emergency, because we are not existing in a bubble. And equally, what we would always do, we monitor, we always, and that's where the incident management approach comes in discuss with the stakeholders that are particularly involved, and then get expertise. And that's why I'm really grateful as well for the collaboration with partners, but also really within the council, really strong collaboration. So public health brings one aspect, but then public protection. So Chris Lee's outfit and the officers, their environmental health officers, the enforcement teams, they have a lot of experience that we can pull together to come to in these decisions. And what this group brings is the community voice, and what this group needs to broker is, if decisions have been made or need to be made, that we do them as much as possible with the community, rather than the community waking up and finding things are imposed. Now, The reality is that we've seen twice now in Leicester as well as in Greater Manchester, central government comes very quickly. And then we all have to fall in line. But we want to do what is within our powers to do it as well and as aligned with our community as possible.
Thank you. Rebecca, did you want to come in?
Thank you, Stephen. Dagmar, I just was reflecting on the point that you made around the risk of a second wave, particularly ahead of winter, and the potential challenge in differentiating, I suppose, between COVID and flu. And I suppose what we're able to and what we're planning around communicating to people that, I suppose, A, it's safe to go and get a flu vaccine and where that would be, but also encouraging people to still get tested for COVID during that period. And I suppose just generally what our plans are for that and what we're able to do.
Yeah, so I think it's a really important and good point that you pick it up. Respiratory illnesses are quite similar. You know, a cough is a cough, and a fever is a fever, and there's plenty around. And the more we move towards autumn and winter and people are inside, the more we will have. So the idea is that having flu on top or concurrently with COVID is really not a good idea, because we need all our staff, we need all hands on deck. And can you imagine if people have COVID and they have flu, who's going to look after in our services, etc. So therefore we are saying there is really, really no reason whatsoever not to have the flu vaccine. Yeah, at least then we can keep flu at bay. And that's why the government has announced as well a big push. Many more groups can have access to a free vaccine. So that I think we all can play an important role. And I think you touched on a really important sort of ask: where can they get the vaccine, so that we make access really easy, and that we listen to people in what easy access means for them, rather than us speculating what we think easy access is. Yeah, and one route, for example, which is well tested and generally well trusted, is the community pharmacy, for example, and obviously for higher risk groups, primary care plays a really important role. So that's for us to do. Obviously, what I'm absolutely praying and hoping and trusting is that the supply will cope with the increased demand. So our colleagues in the NHS are beavering on that. We're expecting the first lot of vaccination for the highest risk group to start in the middle of September.
Thank you. Any more questions before we move on to Dagmar's second presentation? Martin.
Hi there. Dagmar, I was just wondering, how can we get an indication of herd immunity in Merton?
Okay. We're actually not really going after herd immunity. It's a concept that we know from vaccinations more than from letting an epidemic rip. Yeah, the disease is too horrible for at least some people that we can't just say, oh, you know, we let it go so that we develop herd immunity. And you might have followed some of the discussion on what happened in Sweden, where there was a little bit of a mixed approach, where they didn't go down the social distancing route so much, and said, well, we might get away and create more herd immunity. And in a way, it looks almost as if they had, you know, the worst of both. They had quite a lot, a high death rate, particularly in the older population, and the herd immunity still isn't anywhere near preventative. So I think herd immunity is a good concept when you have a vaccine. then that is a safe way to create herd immunity, not with an epidemic that you don't really understand.
Thank you. Should we move on to the second of Dagmar's presentations, and this takes us into the impact of COVID-19 on vulnerable communities. Dagmar, over to you again.
Yeah, so this is only a snapshot. Some of you, because obviously some of us are Health and Wellbeing Board members, so the Health and Wellbeing Board in June, when it first came together again in a remote meeting, had quite an in-depth session on a more comprehensive set of slides around trying to understand the health impact of COVID so far. But what I want to do is bring us a little bit up to speed with a snapshot, so that we can then understand what our role is in terms of the lived experience oversight. And if I just draw your attention, it's a bit of a sloppy cover slide. I really should say health impact, because as we've already alluded to, and Stephen very clearly alluded to, COVID impact is vast. It's affecting the whole society. I'm talking about health impact. And indeed, at the moment, I'm talking about the direct health impact, so death from COVID disease. There's a lot more. There's quite a lot of health impact that is indirect. COVID health impact that's indirect. You will have heard quite a bit about mental health. You know, people have quite a bit of mental health impact, even if they haven't got COVID. People might have missed important health service appointments, a whole discussion around cancer care and how they're getting back on track. And then, as we've alluded already, all the social impacts that COVID has have then a knock-on effect on health. So loads that we need to unpack as a Health and Wellbeing Board over time as more data become available. But here I'm just using two snapshot slides about death from COVID in Merton. So if you give me the next slide. So this is quite a, this is the sort of the sobering slide that you will recognize now. It's the classic curve. And in what it shows you are the excess death that we had. And you can see our peak week was the Easter week, 11th of April to 17th of April. And the way you read that graph is that when you see that wiggly yellow line, these were the weekly deaths, a rolling average in 2019. And when you then look in that middle week, there's a really big additional number of deaths. And what was most disconcerting when I saw this slide first was that when you look at the color of the spikes, that actually blue is COVID and orange is non-COVID. So in that peak week, we did have 51 COVID deaths, but we had 107 extra non-COVID. That was quite disturbing. And we're still unpacking that, because we want to make sense of it. Some of the explanation is most certainly misregistration. So you will remember that we didn't test everybody, particularly people who died outside hospital. And because COVID can be such a chameleon, particularly with in people with who have other conditions, that we think amongst the orange bit there are quite a few hidden COVID deaths. But there is something quite alarming, and it in a way illustrates what I said, in that the impact of COVID is not just the direct impact, but there's quite a bit of indirect stuff. And therefore, the proportionality for me needs to take all of that into consideration. There's also good news, because if you follow that wiggly yellow line and you go into May and June, we actually dipped and now in July again we dipped. That means death in 2019 in July were more than we have now. Yeah, so there is a little bit of a relief, and it is now nationally that we are under in last year. And if you think through what has happened tragically, is that most deaths obviously occurred in older people, and those people already had quite a limited life expectancy, and their death was hastened. But we are now seeing a little bit of a reprieve. So that is nevertheless, that peak is stark and sobering, and we're still unpacking to understand that more. If you give me the next slide. One before, you slipped one, that's it. So this is just an example of some of the inequalities or disparities, whatever we want to call it. On the left-hand side, you see the classical East and West divide, and you feel it, you see it again mirrored in COVID death. The discrepancy at the beginning of the epidemic was more crass. The second lot was slightly less so, but nevertheless, we have not escaped our East-West divide in COVID deaths. And on the right-hand side, I think are really striking maps. If you understand the size of the red dots tell you the COVID death, and the bigger the dot, the more death. And then the underlying shading shows you where our population of ethnic minorities live. And even more dark are the occupations that predispose you to COVID. And it shows you some of the drivers of in some of our COVID vulnerabilities and death. So occupation is one of the biggest drivers, and it is occupation that is poorly paid generally, that exposes you where you have little agency to do anything about it. So that's in high risk, and that is something for us to really consider. If we go to the next slide, I think this slide is a really good reference slide for us to remind ourselves, what do we know about the biggest drivers of the disparate COVID mortality, and that is across not just Merton, this is across the whole country. So age is by far the biggest. So Rob, Age UK, big role to play, and within that cohort, people with dementia in particular, very vulnerable. I pick out obviously BAME has a lot of rightly so attention. I think irrefutable, the association about people from BAME backgrounds having more infections, more hospital admissions, more ITU, and more death. And again, what is really, really important are the most important drivers are deprivation, occupation, as I already said, the one without control and big exposure, and housing, overcrowded housing. And if you think about it, that's how infectious diseases over the centuries have singled out the more deprived, because that is the sad story of history. But what is also important is that these are all socially patterned. That means we can do something about it. And underlying health conditions are the other important driver. So particular diabetes and cardiovascular disease, more than respiratory diseases, to some people's surprise. But what is also important is that these are not all driven by biology. because those who are particularly obese, who have poorly controlled diabetes, poorly controlled hypertensive disease, are the ones that suffer disproportionately from fatal COVID. And this is again socially patterned. If you look, who are those? So we can do something about it is the big message. And if we move on, the last slide is the so what is the Health and Wellbeing Board doing about it? And again, when we discussed in the COVID impact in the Health and Wellbeing Board, in that slide said there are the full list of recommendations from the Public Health England report. So if you ever want to see that as a reference, I think we can send that round with the minutes. So our work program is very much following the evidence from those recommendations. So one is we want to better understand the impact. So more analysis will happen, but more importantly is we want to hear and listen rather than come and have the answers up our hand. So we've commissioned qualitative, what we call action research engagement from our voluntary sector. BAME Voice is the first of the groups that we have commissioned to do some work. We're very, very keen that it's asset-based, so that we're not just having a long list of what the problems are, but that we are tapping into the creativity of the community to think, what can we do about it? And we're then planning, informed by in our data and the more national review, age, dementia and carers as a group that has suffered particularly. And then we want to also concentrate on people with learning disabilities and autism, because you will have heard a group that is often disenfranchised, but also has taken them in a lot of suffering. So that's the lived experience piece of work. And I made it in red because we need to register that we as the subgroup have to keep an eye on it, be the sounding board, and also be the conduit in a way between that piece of work and the Health and Wellbeing Board, so that we then make sure that we turn the lived experience into action. The second really, really important bit, and for me, God, that's what I want to get my teeth in now, is the immediate protection of the most vulnerable. Because as we've just said, we might have another month or two, if we're lucky, maybe 3. And we know now some of the underlying mechanisms of what can help us with outbreaks and what can help us to get people a bit more protected. So we need all of your wit, creativity and connections to get bespoke and trusted comms and engagement about outbreak control. That's why I laboured a bit, because you need to be the conduit. And obviously we need to think very much through how we do that and how we enable you and how we help you. There is actually loads and loads and loads of material around us. But the question is, the material on its own doesn't do it. We need channels, we need trusted connections. And then the second really important bit, and I've just this morning with Vasa come from our Merton Health and Care Together partnership. We want to do bespoke prevention programs focused on the most vulnerable, and we call them COVID fit. That means get your lifestyles a bit in order, get a little bit weight off if you have too much, up to your physical activity, stop the smoking, just the usual stuff, but very, very focused. Now, under the umbrella, if you're in slightly better shape, you have a much better chance. Then what we call prehabilitation, that's a sort of new word creation. It's not rehabilitation after you were ill, but prehabilitation to get you into better shape before you potentially get COVID. That's the stuff we talked about. If your diabetes is poorly controlled or your blood pressure out of control, your chance of serious COVID is seriously worse. So why not calling these people and help them to get better control? Flu IMS we already mentioned, and I did mention mental health and well-being because the feedback I'm sure you had, I had, is that fear, anxiety is quite prevalent. The community, in some parts of the community, have had real tragedies, and multiple members of families have died. So there is a lot of fear, there is a lot of grief still out there, and it has taken its mental and emotional well-being toll. So that's where we want to get our teeth into. And then not to forget, because sometimes when I get all excited about now rolling my sleeves up and get going, people say, oh, you know, that's just window dressing. Inequalities are deep-seated. And I'm with you. They are deep-seated, and I'm not going to forget them. It is simply a bit of timing and energy. Medium and longer term, absolutely. This is, in a way, COVID has woken us all up. It has is shining a rather harsh and nasty light on inequalities, but it also allows us a reset to be safe, fair and green. So we're working very much on the recovery side to create that Merton as a healthy place with real focus on wider determinants, as well as with our Merton Health and Care Together health and care partners, holistic care. And just some of the examples, the climate action plan went through cabinet, transport strategy, that are the tools that we have to longer term shape Merton into a healthy place. So that's what the Health and Wellbeing Board overall is up to. And for us, the two red bits we need to get our teeth into. That's it. There's always one last slide that I'm not going into, but it's the lovely voluntary sector slide to say, how can I volunteer and how can I get help? And it's such a lovely slide that I put it at every presentation I give, so that people have something in their hand as a little reference.
Thank you very much, and very important work that we're tasked with. Just before I open it up, just a question from me on getting that lived experience, and that's going to be via BAME Voice, which the council has commissioned. Just talk us through a bit more about BAME Voice, who they are they based anywhere, how often do they work, how often do they meet?
Yeah, so I am probably not the best for all the details. It's fair in comment. One of the suggestions is, because it's only just happening, so we're commissioning them, we have proper specs, in our next meeting we get our teeth into that lived experience piece a bit more. So they are our main, and I'm looking to Rob to help me a bit out, our main BAME voluntary sector organisation. And the idea is that, in a way, the lived experience, as I said, we stage it a bit. So we start with BAME, but age, dementia care, as we've already discussed with Rob, it's a really, really important group. And then equally learning disabilities and autism. And so the expectation of BAME is that they work with other voluntary sector groups, because obviously there are a number of very small ones, because some of our community groups are smaller, but very important to connect with them. And that they also are really open and diverse, because one of the feedbacks I have got from JCC as well, and various other fora, is that people got irritated about BAME a bit. They say, BAME what? You know, you all lump us together. that's actually really quite offensive because we are very heterogeneous. So I'm doing it because, you know, ONS, our Office of National Statistics, just gives me those categories. But I'm very, very aware that with your help, we just can do justice to the diversity of our community. And what is very important in the spec we've given the voluntary sector group is that they will run focus groups, etc., but they will also help us with the active communication around outbreak control. Yeah, so they do the double whammy. And because we've got Martin here, and I was very, very keen to have Martin here, it's really important that we consider young people, although young people haven't been affected directly by COVID in terms of COVID deaths, thank God, but they have been affected really heavily, indirectly by COVID and into the future. So it's really important to listen to them, to understand their experience, but also again, tap into their assets. You know, I'm unashamedly a fan of young people. I think we use them too little in their creativity. For COVID, we've stereotyped quite a bit. You know, they're the lot that don't socially isolate and party. That's the sort of a message that the media often portray. That isn't the full picture. I think I would love to tap into their help to get community cohesion going. So that was part of the spec, that it is young people, middle-aged, older people, the lot.
Thank you. Rob, do you want to come in from Age UK, and then we'll go to Martin?
Yeah, I mean, what you said about BAME Voice there, Dagmar, is correct. I suppose their role is to almost bring in the different community groups that exist within the borough and seek to represent those specific views. And I think it's absolutely right to say that for example, the Pakistani community's experience of COVID is likely to be completely different to that of the Caribbean community, and we really need to be able to kind of reflect that each individual community's experience and get our reach out to them as best that we can. So I would endorse everything that you've said there. I guess from an older people's perspective, I mean, I could probably quite quickly characterize some of the issues that our client group are facing in terms of, you know, both direct and indirect. We know about the health impact on older people, but actually, I guess they're also disproportionately affected by the indirect as well. So the issues of isolation, loneliness, anxiety, loss of confidence, and even things like quite rapid deterioration in mobility, leading to frailty and increased risk of falls. All these sorts of things are huge byproducts that actually affect the individuals in question, because we've asked them to shield and not go out to all those things that would have helped them to maintain all of that kind of health and well-being. And I think that the rapidness of some of that deterioration is quite alarming. It's some of the things that we are seeing with our client group are quite concerning. So I guess it's really important that their voice and their concerns are heard, and we're certainly doing a bit of work with Dagmar's colleagues in public health to capture some of that from a lived experience perspective and almost represent those thematic issues that we're seeing on the ground. You're on mute, Stephen.
Yeah, I'm taking a bit of a liberty. I've asked Rob to come in, although he didn't put his hand up, but that was a very good contribution. And I'm now going to ask Martin to see if there has been some stereotyping of young people and just his general views. Martin, over to you.
Hi there. Yeah, I think there has been a bit of stereotyping, but I think what Dagmar's kind of said about the indirect impact of young people, and obviously it makes sense, you know, schools closed down, colleges closed down. Some of the young people are stressed because of them not being able to take exams. So now kind of having to look at universities not really knowing where they stand, having to accept the teachers' assessments, even though they can't take an exam. So it's been very stressful for them, plus any ongoing health difficulties that any family member might be having, obviously is going to impact them as well, being locked down for such a long time as well. But other than that, I mean, just to add to what Dagmar's been saying, we obviously, from the participation and engagement and working with young people, I think we can definitely use the youth network we already have in place within our youth clubs, within our youth parliament, within our voluntary organizations that work with young people, and see how we can continue the kind of engagement that will be able to get this creativity we need to keep the conversation going, and to reach new people essentially, and to reach new communities that maybe haven't been engaging so far. And so I think that's what is great about this particular piece of work.
Thank you. Rob, did you want to come back in?
Just to endorse that really, and I think kind of what we've seen around the issues around the environment and climate change. I think young people, we do them a discredit. I was once a young person and I felt discredited, I have to say, in terms of their ability to influence adults. And I think actually, if we're seeking to kind of get messages out into communities that are harder to reach, actually having sort of young people very much engaged and involved in that, they're going to talk to their grandparents about the issues that are very real and for those high risk groups. So I think actually having that kind of upswell of young people involved, I think is really, really critical to this in terms of the wider engagement.
Thank you. Ellie, did you want to come in?
Me?
Yeah, did you want to come in?
I was being distracted by my daughter being dropped off back home. Very many apologies for that.
That's all right.
No,
Yeah.
that's all very clear. I'm really supportive of the work that we're doing with BAME Voice, and I've already put them in touch with a few people in my ward who I think could provide some useful input.
Thank you.
And I also, may I, Stephen, sorry, Chair, just in quick response to Martin, that when we think back in terms of our direct remit around engagement and communication around outbreak control, I was also really thinking about using digital media in a agile and appropriate, age-appropriate way. That we, I think, and we're very blessed in Merton actually, because the comms has been really good, and they have upped the ante on the social media. But I'm looking to Martin as well to help us with the input of young people rather than our oldie prejudice, to help us find new channels and ways of communicating, and the messages themselves, the testing, the contact tracing, some working about why people wouldn't do it, what are the myths out there in their own communities, could they be good examples? All of this is pretty tangible, concrete stuff that I think we can get our hands dirty now.
Thank you. We're on good timing with regard to our timescale. Any more questions before I move on to the next item? Just to confirm, Dagmar, that the primary work of the subgroup on the impact of COVID and its disproportionate effect on the BAME community, but also looking at age and sex and other issues, and gender and other issues, that we're here to primarily concentrate and tease out the lived experience, and how do we work on when there's an outbreak of the pandemic locally, just so that we can focus. And is that correct?
Yeah, absolutely. And on the outbreak control, we want to do a bit of prevention as well. So we want to proactively engage with our communities in case there is an outbreak, and to prevent an outbreak.
Okay, thank you for that. Una, Councillor Una Moulton.
Sorry. No, I just was really wanting to underline that, because I think that I've just picked up on that, because I actually think that is somewhere that we can really help with as councillors in particular, and sort of getting out into our wards. I mean, I'm Wimbledon Park, and I know, you know, I'm on the west of the borough, so and I appreciate it's the east, but I mean, the more we can put out through our sort of social media and stuff, these sort of very simple prevention things, in a sense, you know, obviously we can't prevent a whole pandemic coming into our community, but we can prevent at least maybe some of the worst effects of it by getting, I mean, I like those sort of ideas and ideas within our wards to do things, whether it's encouraging people to get on their bicycles or whatever it is, you know. I think there is stuff we can do, so thank you for that.
Chair, you are mute.
So we're moving on to our last item, which is the terms of reference. Dagmar, do you want to take us through this?
Can I actually ask Clarissa? Clarissa, can you briefly talk us through the terms of reference? Is that all right? Thank you.
Yes, so we circulated the draft terms of reference to the group, and hopefully you all received them and maybe got a chance to read through them. I don't know how you want to do it, Chair. Either we could take comments now, or we could give people a chance to email comments through, maybe in the next week or so. Whatever you think.
Yeah, what I like to do with terms of reference is, just in case members have picked up on something, so go through each head.
Right, that's fine.
To say something.
Yes, okay. Yeah.
Right, that we can take this off field and people can come back to you if they thought of something and or they wanted to change something. So we've got the terms of reference. Any comments on so I'm going to go through the headlines. Purpose. Any comments on context? We're on to responsibilities, Roman numerals 1 to 4. Has anyone spotted anything there? This is not to say you're approving this completely, it's to give you an opportunity, and then you could go back to Clarissa later. Principles and priorities. On the membership, we've got the young inspector there, which we're all very happy with. On accountability, and we report to the main health and wellbeing board there.
This usually meets
to 6 weeks. Duration and setting of meetings, 90 minutes. I think that's about right. We're actually doing quite well now. We're nearly on 90 minutes for this meeting. Agendas, papers, transparencies. So all the minutes will be public, and as you know, this is a public meeting on YouTube, and we welcome all viewers. Are people happy with the quorum? Look, 4 members. At least 1 member from each of the following constituent groups: council members, council officers, Merton Clinical Commission Group, voluntary sector. Martin, that doesn't mean you get away with it. We'd like you at every meeting if possible. And, obviously, code of conduct, conflicts of interest. I think that's something that we do here in Merton throughout all our meetings. And there is that duration of the community subgroup, Dagmar said, towards the end of March / April 2021. Any comments on those terms of reference? And as I said, we can all go back to Clarissa if we spotted everything. I'm relaxed and content and happy with them, but please do feel free to communicate with Clarissa if you spot anything, and she'll come back to all of us with any changes.
So I will do, Chair, and just to say, we'll then take them to the Core Health and Wellbeing Board on the 28th of September, subject to any comments that anyone sends through for agreement.
Yes, yes, the main Health and Wellbeing Board, we will look forward to seeing those. So I think we're at the end of our meeting, but unless there is any other questions, I'd like to thank Rosie, Clarissa, Stella, Ola, and all of you for your attendance, and particularly to Dagmar and for her excellent presentations. This concludes the meeting of our Health and Wellbeing.
Thank you very much. See you.
Bye-bye.
Thank you.
Thank you. Bye.
Bye-bye.